Welcome everyone to the Implementation Science Seminar. We're excited today to have our awardees, pilot study awardees, presenting on their projects. And this is just one of the ways in which we support implementation science here at UCSD through these projects. And we also have a number of other supports, such as conference travel, which we don't do much of these days, but hopefully will soon. Funds available for article processing charges, things like that. So please, if you're not a member, become a member and look at some of the benefits we have. Want to remind folks, if you haven't signed in already, here's the QR code. You can sign in, and we've put that in the chat as well. Jamie has put that in the chat. Let's go to the next slide then. So for this seminar, please use the chat function to ask questions, and the moderators, our hosts, will sort of moderate that and read questions for our presenters afterwards. Each presenter will have 15 minutes and then 5 minutes for Q&A. Just a reminder that DISC pilot grant applications for the next cycle, for the 2022 cycle, are due December 15th. So don't delay. If you have a good idea, we'd love to see it. And the Journal Club, DISC Journal Club, this Thursday is featuring Dr. Bethany Kwan from the University of Colorado Health Sciences. And so that'll be a great meeting with Bethany. So with that, we'll get started. And we have three presenters today, Dr. Rebecca Fielding, Dr. Ryan Moran, and Dr. Emily Treichler. And Dr. Fielding Miller is an assistant professor at UC San Diego in the Herbert Wertheim School of Public Health and the Division of Infectious Disease and Global Public Health. She's a faculty member of the Center on Gender Equity in Health and has a program of research that's community-driven, examining drivers of COVID-19, HIV, and gender-based violence in the US and sub-Saharan Africa. Rebecca will have to talk about that offline, with a focus on intersection of race, gender, and economic inequality. Our second presenter, next slide please, will be Dr. Ryan Moran, who's an associate clinical professor in the Department of Medicine and Department of Family Medicine, certified, board certified, both internal medicine and preventive medicine public health. He's a primary care physician with an interest in better understanding aging, resilience, disease prevention, and wellness. And finally, Dr. Emily Treichler is a clinical psychologist, assistant professor at UC San Diego, Department of Psychiatry, and also at the VA San Diego. She works alongside stakeholders in community settings to improve quality of life and quality of care for adults with serious mental illness, and uses mixed methods and implementation science strategies in her work. So with that, why don't we launch right in? And Dr. Fielding Miller, if you want to take the stage and share your screen.
Great.
That'd be great.
Thank you so much. Now we play the game where please let me know if presenter happens to be facing you all. I think we got it.
Looks good. We can see it.
Beautiful. Okay. So I am so happy to be here to share with you all and have the opportunity to talk a little bit about some work that I've been doing in partnership with a refugee advocacy organization here in San Diego called PANA, which stands for the Partnership for the Advancement of New Americans. So I've been working very closely with them for a couple of years now. And last year, they approached me and said, you know, every other year we do a report on the status of the refugee community here in San Diego. And we really want to make sure to include some COVID-19 questions this year. So they asked if I'd be willing to work with them, and I was really delighted to be able to do so. So what I have done in part in support with some of this DISC funding is we worked with PANA to field a pretty large survey of the refugee community here in San Diego. It was a convenient sample of about 544 clients or community members who PANA has worked with or touched in some way in the last 5 years, whose contact information they had. And together we built a survey with about 70-something items covering lots of things that were of interest to PANA for advocacy purposes and just to have a handle on what's happening with their community here in San Diego. So a lot of PANA's work here centers around advocating for better housing, for better support, better structural supports, and also just understanding what it is that the community here in San Diego needs. So we did an interviewer-administered survey. Folks called people up over the phone and administered this survey in Farsi and Arabic and Somali and Swahili and Spanish, Karen. And we ended up with this really big, beautiful sample that was about 38% East African, predominantly Somali, but also a lot of folks from Sudan, Ethiopia, the DRC. About a third that were from Iraq or Syria, predominantly from Syria, and a pretty big proportion of folks who were from the Afghan community who were Farsi speaking, and then a reasonable sample of folks who were Karen. So this survey, it was fielded in October and November in 2020. So when I present some of these data, keep that in mind. Vaccines weren't quite available yet, although they were on the horizon. But we were pretty deep into this pandemic by then. So what we wanted to do with these data was really a lot of the analyses and the approach were driven by PANA in this kind of action research tradition of we didn't want to just ask questions just for the sake of curiosity. The goal was always to really be able to say what does their community need right now, and what data can we present for policy and change purposes? What can we use to advocate for the community and to show that this is what is needed right now? This is what's happening right now. So one of the first things that we were really interested in, and this is sort of what the application that I wrote to DISC centered on, was what are determinants of testing in the immigrant and refugee community, and do these significantly differ by where people are from, by cultural background, by SES. And so we put together this structural model where we thought about, okay, what are reasons why people might test or not test? And in this survey, that again, we fielded in October and November of 2020, about 75% of people had never accessed a COVID test. And I want you to think back to where we all were in October of 2020 and consider if you yourself had never gotten COVID tested 6 months in, 7 months into the pandemic. It was pretty common at that point. So that was a pretty startling number. And so we knew from doing some other work with the Latino and Hispanic community that there were a lot of concerns about testing and immigration status. Will this affect public charge? There were a lot of concerns about living in crowded housing and contact tracing, and I can't isolate, so what's even the point of testing? And we knew that there were concerns about sort of self-efficacy, so feeling that you could overcome the fact that maybe testing areas were far away, or you didn't know how much it costs, or maybe it was going to hurt. So self-efficacy is kind of the ability to access a service anyway. And we thought that was probably a pretty big determinant. And then we thought probably age would play a role, and whether or not people spoke English, because there's not a lot of materials out there in Somali or Swahili. And so we looked to see, this was kind of our model of what we thought was going on, that speaking English and age would maybe moderate testing self-efficacy. And so we looked to see if all of these pathways were common across all the communities or if they differed. And what we found was really interesting. So a lot of these pathways were really similar. Being older, folks who were older felt a little bit more able to access a test. But we found that people who had higher self-efficacy to access a test were more likely to have accessed the test. Not exactly surprising. People who were worried across the board, people who were worried about their immigration status, were less likely to have accessed a test, which really lined up with a lot of what we've been hearing in qualitative work all around the county with different communities. People who were employed were more likely to access a test, which makes sense because if you're employed, you're probably at a higher risk of exposure. But we also found a couple of peculiarities. So we noticed that in the Afghan community specifically, living in more crowded housing was associated with a lower likelihood of testing. We also saw this really interesting dichotomy where in the East African and Afghan community, speaking English at home was associated with higher testing self-efficacy, which kind of makes sense. If you can read the materials, you can access the materials, it feels more comfortable. But in the Syrian community, the opposite was true. People who reported that English was spoken at home had lower testing self-efficacy, and we're still trying to figure out what that's about. And so we're still really in the middle of parsing this out, but these are some interesting similarities and differences across the the refugee community as a whole. And the hope is to really be able to drill down and say, clearly there are issues with crowded housing in the Afghan community. Let's go out to El Cajon where there's very crowded apartment complexes and make sure that those folks in particular have materials that are tailored to their needs. So housing has been an enormous issue for PANA for years. And you just saw kind of a hint at that, where people who lived in more crowded housing were less likely to have access to test. And this is a commentary that the director of PANA, Ramla Sahid, wrote a little while ago about the importance of eviction moratoriums and sort of the risk of losing housing during COVID. And so we did another analysis where we looked to see among people who were living in severely crowded housing, which is more than 1.5 person per room is the definition by the state, which is about 30% of the refugee community as a whole. We found that people who lived in severely crowded housing were twice as likely to have not accessed a test. So in other words, they were half as likely to have accessed a test. And they were 4 times more likely to report poor emotional health. And it was really important to us to drill down on this because, again, housing has been a huge piece of PANA's advocacy work. And so being able to specifically link this to health outcomes related to COVID, related to emotional and behavioral health, which the county has been making a big push for, it was both good science, but it also allowed us to immediately link into work that they've been doing at the county and city level to get more resources for the community. And one thing that we found along the lines of being able to make specific policy pushes is that, not surprisingly, affordable housing is protective against living in severely crowded housing. So we asked folks, do you have access to Section 8 vouchers? Are you living in an affordable housing unit? And people who were using affordable housing resources were 61% less likely to be living in severely crowded conditions. And so that makes a really clear, really easy policy argument for PANA, supported by pretty good data. So a couple other things that we're looking at, again, just in partnership with them, is one major issue in the refugee community is people will often get kind of cut off from a lot of government services at about the 5-year mark. That's when you're no longer eligible for employment support and a lot of things. And so we also asked a lot of questions about how the pandemic has affected your community. Have you seen more job loss? Have you seen more food insecurity? Have you seen school interruptions or violence or substance use? And we found that this 5-year mark for how long people had been in the country had a pretty big role to play in how much the pandemic had affected folks. So people who had been in the country for more than 5 years reported levels of food insecurity that were 5 times higher than people who had been in the country for less than 5 years. People who had been in the country for more than 5 years were twice as likely to report school interruptions, and they were 5 to 8 times more likely to report that household violence or substance use had increased in their communities. These are still really early analyses. We're still working on these, and there's like confounders and things we need to tease out in the data. But overall, controlling for a lot of different stuff, we found that the pandemic really hit people harder the longer they'd been in this country, and specifically if they'd passed that 5-year mark. And again, that analysis was really driven by PANA's work advocating for longer supports for folks when they come here. And they've separately done a lot of work with economists and other experts kind of showing that like that's, in addition to being a good thing for public health and decency, it's also really great for the economy. And they've done some other work looking at how folks are more likely to start small businesses and work as entrepreneurs. But what this does is it really, again, gives PANA the ability to go directly to policymakers and say, we need food banks in this community. We need to target folks who have maybe been here longer, not folks who just got here last week, because that's where the resources are necessary. So that was kind of in keeping with my 15 minutes, a really kind of super broad overview of this work. But because this is a group that's really focused on implementation, I think that it's really important to talk about for a second this really participatory action approach that we took to collecting and analyzing the data. So as everybody here knows, manuscripts are an important part of the data sharing and the research dissemination process, but they're really only a small part of it. And really every step of the way in this process has been driven by what PANA wants and what PANA needs, and they are deeply rooted in their community and knowing what their community wants and needs. And doing that ensures a much more rapid translation for advocacy, for policy change, for implementation. It also, COVID moves incredibly quickly. And so being able to do these kind of rapid, maybe less fancy, but still important analyses has enabled people to really advocate for things in the community. For example, we noticed a lot of families reported that their kids didn't have headphones when people were engaged in remote learning. Well, that's a fast and easy fix. You don't need a manuscript, you just need to pass out some headphones. So things like that, working really closely and constantly allowed us to be really nimble. We've also really focused on capacity building and partnership. So PANA leadership, they're all co-authors in this, as they should be because they put the work in. But we've also worked really closely with some of their younger staff who are maybe planning to go on to a master's program to think about, what do you specifically want to learn? What's useful for you? How can we partner together so that this is an actual partnership and capacity building experience? So PANA has the internal skill set and resources to do this on their own. And again, I know I've said this like 9 times, but at all times, just making sure that the work is guided by PANA's advocacy goals to make sure that what we're doing is immediately useful, because it's their data and their community, and being useful is good public health. So that's my maybe 60,000 foot overview. I'm happy to answer more specific questions. I know that was a lot in a short time, but if any of you are interested, PANA will actually be having a Human Rights Day of Action on Thursday. It should be really fun, and you should go check it out if you have time. Thanks.
Thank you, Dr. Fielding Miller. In the interest of time, we're going to hold questions for the end, but just great presentation. Love to see that community engagement and how you're really integrating that feedback as well. So if I can ask Dr. Moran to come on and share your slides. All right.
All right. Good afternoon. Hopefully everyone can see the slides in front of them.
Yes.
Wonderful. Well, really a pleasure to be here. I really appreciate the opportunity. So my project is centered on integrating a more comprehensive fall prevention program within our health system. So fundamentally, as was alluded to earlier, I'm a primary care doc. I see patients most of the time with a huge interest in trying to bridge a lot of the clinical care processes with a lot of what we know already in the research setting. I think this is the mandatory disclosure slide that your website said I'm supposed to put up, but unfortunately, there's no other bullet points there for funding. And for the sake of time, as succinctly as possible, the background of the project is that unfortunately, falls continue to be a big public health problem. And there are many things that can be done to decrease the risk of subsequent falls or decrease the risk of primary falls. However, they're often not done as robustly as they should be done in the clinical setting. So here within UCSD Health, which is not unique, the current quality metrics, which were bound by many healthcare plans, including Medicare, is to simply ask the question, have you fallen in the last year? And really falls short of doing anything else. So to align our clinical measures more consistently with what's recommended by many different public health groups, including the United States Preventative Service Task Force. So I wanted to evaluate a program to better implement and integrate known science within our clinical setting, study the barriers as well as the successes, and to model a new program for clinical referrals, which I'll talk a little bit about during this project. So the specific aims are stated here, but as before, it's to pilot fall prevention comprehensive shared medical appointment model and to integrate this as robustly as I can within our existing electronic medical infrastructure. And then to evaluate a lot of the metrics along the way. A couple hiccups, which I'm not going to spend too much time on, but it turns out that there's a new committee that was created called the Aligning and Coordinating Quality Improvement Research and Evaluation Committee, or ACQUIRE. This committee was specifically designed to help projects like mine get launched a little bit sooner than the IRB can do, basically to improve known science with clinical measures within the clinical setting. So I submitted to IRB and they said this should really go to ACQUIRE. I submitted to ACQUIRE and they said, well, but there's some research pieces here. We'll do it as long as the IRB approves it. So then it had to get resubmitted to the IRB with this contingency. And ultimately it was approved in September after the initial submission in March. In addition, because of the clinical process changes, I had the opportunity and the pleasure to meet with risk management, billing and compliance in the Office of Coverage Analysis, all of which had some, I'd say, recommendations along how this project could finally get started. The process flow map is shown here, and it basically shows in the clinical realm how my project comes to be. And it's a bit busy, but the short of it is once a patient is identified through a couple measures, which I'll talk about later, they can be referred within our electronic medical interface to a fall prevention shared medical appointment model, which again, I'll talk about very soon. Once that occurs, they can get scheduled where before meeting with the clinical team, including myself, there's a comprehensive fall risk assessment performed by a nurse visit, which is where the consent is performed to be able to be part of a shared medical appointment model. Shared medical appointment, for those of you who might not be aware, is the invoked term for a group visit. So group visits. The group visit is performed ideally through Zoom, which was how the project was initially put in. However, a couple changes have been made with regards to that, which I'll talk about later. But ultimately, depending upon risk, interest, and patient multimorbidity, they might be offered to do the kind of more conventional research piece of this, which is a de novo created UCSD Health Fall Prevention Program called Strong Foundations, which I'll talk about our pilot very soon. Our nurse visit was integrated fully within our medical record. Our nursing staff here at UPC Internal Medicine, which is the clinic that I'm in right now, was all trained in October to perform these comprehensive fall risk assessments, which is endorsed through the Centers for Disease Control and Prevention, which include a timed up and go 30-second chair rise, orthostatic vital signs, which are basically checking different vital signs or blood pressure and pulse in different positions, so standing, sitting, and laying down, and then a validated eye screen for eye concerns. So I'm giving a presentation, sorry. The shared medical appointment is also signed there, and then once that's all performed, the encounter is routed for scheduling. The shared medical appointment model is physician-led, but is definitely comprehensive with many of our house staff, so residents in preventive medicine, but we've also had exercise specialists and physiologists be part of this to provide additional insight in terms of fall reduction. We do a number of things aside from review the nurse visit. We review their medical history as well as the medication reconciliation and make recommendations on changes should there be any that balance benefits and risks. In addition, clinical referrals are placed if they're thought to be appropriate based on patient concerns, previous histories, or information discussed or found. Our first shared medical appointment was launched in early November, and they occur every other Friday. Currently have been Zoom hosted. The feedback has been overwhelming that older adults actually prefer to do it in person. So we've recently gotten approval through Acquire to be able to augment that as long as individuals are vaccinated and appropriately spaced. So those will launch in January. The first iterative shared medical appointments were kept small so that we could get really valuable feedback. And so far, overwhelmingly, the feedback has been fairly positive. Many clinical measures as well as survey measures are being collected along the way, but because of the low end, we've not looked at it yet. We refer to many different fall prevention programs throughout the county, depending upon patients' geographic location, as well as interests and risk factors. So this is not actually a comprehensive list of some of the community-based organizations that are free or are very low cost. And again, they all have specific indications depending upon specific clinical or patient concerns. So for example, Moving for a Better Balance, which is offered through UCSD and Scripps, is really designed for those who have a fear of falling, more so than any sort of physiologic reasons why they're at risk for falling. There's also several online resources which we've been iteratively improving how we can integrate this in a meaningful way, which I'll talk about a little bit later, but many very, very good sources through very valid, credible organizations. As I said before, one of the other components of this project was to see how we could hopefully work to transform care to really systematically implement fall prevention programs through a referral-based system. So we've designed a program called Strong Foundations, which was really lifted by a number of exercise physiologists in fall prevention. And this is a virtual bone health and fall prevention / fracture reduction exercise intervention. And we've completed the pilot, which was an abbreviated 4-week program, which I have some data to share with you in a second. And our full launched program for the first cohort started in November with 9 participants, so many of which from our clinical setting for direct referral. And our next cohort will begin in January, mid-January, January 20th, I think. So this is a Zoom-based with instructions with homework for participants to do along the way, with many different measures being collected, including feasibility metrics, as well as a couple measures which I'll share for right here. So effectiveness. So whether or not individuals thought that this was from our pilot. So remember, this is just 4 weeks, so 12 individuals in just 4 weeks, but it was really important for us to make some changes along the way. So by and large, you can see the color coding. Strongly agree and agree is the purple and the green, which hopefully shines out as being the larger amount of the data there. But there are some things that we learned there. So, for example, many people were not aware that they were being watched along the way for feedback should something be going wrong. So that was something that we were able to implement when we launched the formal program. And then importantly, from our pilot, we also asked some questions about sustainability. And that was simply saying, do you think this is worth it? And we anticipated the cost, assuming we were able to do 12 people, and then as people progress through the curriculum, the class can subsequently enlarge as we're relatively sure that they're safe, that somewhere between $5 and $8 would actually be able to be sustainable for this sort of program. And most people think that that was actually very reasonable for them. So the next steps is Epic integration is a beast to do. I'm sure other people have done it more efficiently, but the ticket that was placed, even though a big proponent of this program is our Chief Medical Information Officer. So I have about as much momentum as I could push. Even though that's the case, it's still being built for referral throughout our system, which is really important actually for a lot of the measures that we're collecting, including how many people follow through once the referral is placed. In addition, from our first shared medical appointment, three classes that we've had, the shared medical appointments, we've also thought that really a good package approach so that this is really sustainable throughout our clinical system was develop more or less packages. So the worried and well, these are high functioning individuals really interested in reducing their risk further. Individuals who are doing okay, but they have a couple risk factors. This is really the target population for fall risk reduction. Those who have a lot of different things going on, that may be a smaller clinic visit, a smaller shared medical appointment or an individual risk assessment would be more appropriate, or those who are really high risk that really might be best targeted individually. In addition, the questionnaires, so we're using the system usability scale for our digital metrics, so specifically the Zoom-based exercise interventions, as well as our shared medical appointment model, which has not been given out quite yet because we're working to create additional surveys for all the stakeholders involved, including the clinical team. We're also beginning a lot more promotion throughout our clinical setting. So that's where we're at right now. So we're really just beginning to build the momentum of our project. So I guess we're saving questions. Is that right?
That's right. I really appreciate you going through great progress on this. Love to see the data, and the colors are good. Yeah, I've got some questions, but we'll hold those for the end. Thank you, Dr. Moran. So if you want to stop sharing, and then we'll ask Dr. Treichler to turn on camera and share your screen.
Okay, great. Okay, hopefully you can all see that.
Got it. Looks great.
Okay, great. Well, it's so great to be here just to see this other really cool presentation. So thank you so much for having me. Today I'm going to talk about our project and process on treatment decision making among veterans with color, veterans of color with serious mental illness. I want to acknowledge everyone involved in this study, including the DISC, of course, as well as the VA San Diego and all of the members of our study team. So we had 3 study goals going into this study. The first, to create a team, including 2 veterans of color with serious mental illness, and co-design the study itself. The second, to assess treatment decision-making experiences, needs, and preferences of this group, meaning veterans of color with serious mental illness, using mixed methods. And the third, to evaluate cultural tailoring and related considerations for treatment decision-making intervention, collaborative decision skills training, or CDST, and use mixed methods for that as well. We're really at the end of the first stage at this point. So what I'm going to do today is I'm going to talk to you a little bit about our rationale, and then walk you through kind of how we did this co-design process and the changes that we've made from our initial protocol to where we are now as we kind of start to do data collection. So we know that, or it's clear from the literature, that patient engagement in decision-making is good, is important for people with serious mental illness and kind of broadly in mental health and in medical care as well. We know that people tend to want to be involved in treatment decision-making, and we know that it leads to positive outcomes, both in terms of things like patient engagement and satisfaction, as well as in terms of treatment outcomes like symptom improvement. But we also know that there are a lot of, we also know that there isn't a lot of patient engagement kind of on average at this point. And that's both true on average for people with serious mental illness, as well as, again, kind of in the broader population. And we know that there are a lot of implementation barriers that are associated with that. And some of those are specific to people with serious mental illness, like stigma and self-stigma and higher levels of involuntary care. And some of them are not. Some of them impact most people. And there are a lot of reasons to think that those barriers would be more impactful for people of color as a group and people of color with serious mental illness specifically, but we don't really have data to show that for people with serious mental illness, people of color with serious mental illness. What we really have is kind of the downstream effects of that. So we see that people of color with serious mental illness receive fewer evidence-based practices and are more likely to receive coercive care, for example, but we don't see kind of the chain of events that lead to that. We have previously proposed a model that attempts to overcome those implementation barriers, and it's called collaborative decision making. And I just want to walk you through a little bit about how we're hoping that this overcomes these implementation barriers and leads to increased patient engagement. So one of the most common intervention strategies to increase patient engagement and decision making is called a decision aid. And these are great. The idea is that they for a specific decision, help a patient, sometimes and their provider, sometimes and their family, or just on their own, kind of weigh the pros and cons for a specific set of treatment options. And that's great, but the issue is for serious mental illness and other types of complex and chronic conditions, there are often so many decisions to be made, and you don't always have the same options available to you depending on who you are and which health system you're a part of. And so having a decision aid available for every possible decision just isn't really feasible. And so we suggest instead focusing on patient skills and patient competence so that a person can initiate and engage in collaborative decision-making kind of regardless of what the decision is. And similarly, we know that focusing on clinician initiation of a more collaborative decision-making approach doesn't tend to work very well, but that clinicians respond really well when patients initiate. So we focus on that. And that led to the development of this intervention, collaborative decision skills training, or CDST. And the idea behind that is to improve patient skills, knowledge, comfort, and confidence to initiate and engage in treatment decision-making. It's a skills training group, which is a really common intervention strategy for adults with serious mental illness. So basically, we're taking what we already know works in usual care settings and is effective, and really just translating that to this particular problem. It has 6 primary areas, including psychoeducation, assertiveness, empowerment, problem solving, managing conflict, and coping skills. It was initially developed for civilians with serious mental illness, and we adapted it for veterans with psychosis. And we're currently evaluating it for effectiveness and implementation feasibility. We completed a small open trial, and those outcomes look really good. Certainly, implementation feasibility looks strong. And those effectiveness outcomes, although it's a small sample and one arm, those look good too. And we're about to start the RCT. And the sample that we have is a diverse sample, but it's a small sample so far. But the thing is that since there isn't a whole lot of literature about veterans of color with serious mental illness, civilians of color with serious mental illness, we don't really know what the particular needs are for that group. And so there's no particular reason to think that CDST has been optimized for those particular concerns, even though there is reason to think that there would be particular needs for that group. And so we wanted in this project to understand what those needs might be and look at whether there are cultural tailoring needs of this intervention. We used a co-production strategy. I just want to mention what that is. For those of you who may or may not be familiar, this is the ladder participation, which is one way of kind of conceptualizing that idea of co-production. The idea is that for any project, any research project, or sometimes this is looked at also in economics and other types of work, where you're impacting a particular population, that that members of that population should be meaningfully and powerfully involved in all of the aspects of that process. And when we really achieve that idea of meaningful and powerful participation in every single aspect of that process, that's when we get to co-production. And that's something that we're always striving for, is to get to that kind of highest point. We don't always achieve it. Sometimes we're more in the kind of co-design, engagement, consulting areas, but we're always striving to achieve co-production. And so that's what we've been working for in this project. And so we created a co-production team. We recruited through the VA San Diego and hired 2 veterans of color with lived experience. That's one of the kind of difficulties of doing this type of work, of co-production work, is that often there aren't lived experience researchers already in salaried positions at institutions like the VA and UCSD. And so you do need to bring them on. And so that's involved a lot of red tape at both institutions and more at the VA. And so we've had some administrative issues kind of getting them ready so that we're able to start with data collection. But we're now, just about there, and we'll be starting with data collection in January. So I just want to take you through some of the changes that we've made. This is kind of the original study design that we had, where we planned to recruit our participants, veterans of color with serious mental illness nationally, go through the informed consent process, and then have them do a mixed methods assessment that would look at kind of treatment decision-making experiences, preferences, and values, and how those kind of connect to race, ethnicity, and cultural values, both kind of in positive ways, including things like cultural values, but also negative ways, including racism and other types of discrimination. And then we would send them the CDST materials, give them some time to read them over, and then have them give us feedback, including ways that we might need to change it to have it be more attuned to kind of specific needs. And then we would interview everybody else so that we would get all of those CDST interviews done, analyze all of that. And then once we had an idea of what the potential adaptations or cultural tailoring activities might be, we would talk to everybody again and have them rate our potential adaptations. And the first time that I met with everybody, I said, I am so worried about this timeline. This is a lot of activities to get done in a relatively short grant period. And one of our veteran partners said, don't worry at all. This is going to be easy peasy. We're just going to make one little change and it's going to be fine. And I think that it will be. So one small change that we made was just to say we can do this quantitative and qualitative assessment at the same time, as long as the veteran participant prefers that. So we'll leave that as an option. We'll still send the veteran the CDST materials to everybody, and we'll still do the qualitative interview after they've had a time to read it. But what we'll do is we'll ask people to rate their own suggested adaptations based on that interview. And then we'll collate everything during the analysis process so that then we can combine their ratings based on those qualitative codes. We also have a pretty expansive recruitment process, and we expanded it even more during our co-production process or our co-design process. I just want to highlight a couple of things. One of the things we talked about was how to make it kind of more accessible and more engaging to veterans who may not want to make phone calls to people they don't know in order to engage in a research process. And so we made it easier for them to email us, easier for them to engage with us over social media. And we also added some community-based physical advertising rather than using only referral and web-based advertising processes. We also had some discussions about things that are beyond the scope of this particular study, but I think are really exciting for us to invest in the future, about ways that we could have a more interactive recruitment process with people who might be interested, but also might be wary about kind of signing up or creating an individual appointment with a researcher without really knowing them or knowing a whole lot about the study. And so we've talked about things like research town hall meetings and YouTube channels and things like that would provide a more kind of interactive experience for veterans who are curious but want some more information and want to get to know the research team before signing on. In terms of measurement, we had a lot of things that we wanted to achieve here, but also a lot of complexity in each of those tasks. And so the idea was to really be pragmatic while also knowing that a lot of our constructs had not been totally captured in a single measure yet. So we're trying to measure these things related to treatment decisions, related to race, related to racism in terms of both interpersonal racism and structural racism, and find the most relevant measures, knowing that there may not be a perfect measure, without overly burdening our participants. So we ended up adding some measures, cutting some measures, and keeping some measures, and that's how you see them put together on this slide. And I'll just highlight the one at the bottom that's bolded, the facilitators and barriers. I bolded that one because although we did keep it, it was on the original proposal. We really designed this together as a team. It was an idea to measure facilitators and barriers to engagement and treatment decision-making, but we put together that list of barriers and facilitators based on personal experience and lit review. We had kind of a similar need for balance in our qualitative measurement, which was we're asking about complex ideas, but at the same time, we need to be straightforward. We can't ask a question that's impossible to answer. And it was something we talked about with our veteran partners a lot, that veterans often prefer a very straightforward question. They don't want people to dance around the issue, just ask. So we wanted to make sure that we asked questions that were in a way that were how veterans would typically prefer it, and didn't become too complicated. We also really wanted to reduce our redundancy so that we weren't asking things too many times across all of these assessments. And so in that list of a very long list of assessments I just showed you, there are some things that don't even show up because we considered them, but they never made it on into anything permanent because we realized that we already really had those ideas covered somewhere. We also found that it was a lot easier to ask about individual and interpersonal experiences than systemic and structural experiences. And so we played with a lot of our questions in hopes of really capturing that. But what's up next is to really see how we've done as we start data collection, see how those questions work, see how our battery overall works, and ultimately use these findings to tailor and improve CDST. And hopefully, we have big ideas about this, about how we might improve mental health care for veterans of color with serious mental illness more broadly within our local VA and hopefully nationally as well. So thank you so much for your time today. I think we're going into a more broader question period at this point. Be very happy to answer any questions that you have.
Thank you. That was great. I just have to commend the entire panel on staying within time, but there's that. But all of these projects are just so cool and so interesting, so really exciting. So I'm just looking at questions in the chat, and we have one for Dr. Fielding Miller. I'd love to hear more about specific examples of ways that you bring your findings to bear on advocacy or policy. For example, if a research team can't afford to bring headphones to the community, where and how would you disseminate the findings to help advocate for the need?
Yeah, I think that's a really important question because it has to do with the framing. What you're asking really has to do with the framing of who is driving these questions and who's driving the advocacy. So my role in this project has really in many ways been in a backseat. The DISC pilot grant has really covered a lot of my time and some support from a PhD student to help with the analyses, but PANA is really the group that takes this information and decides what they want to do with it. So for example, they've been advocating for a tenants' right board for many years. And so these are sort of data that they can weave into their ongoing policy arguments. So they can say, not only does San Diego need a tenants' rights board, but also, living in crowded housing is associated with 4 times worse mental health. And so it's really not about creating something new. It's about infusing what they already have going on. And really it's what PANA already has going on, not the clever ideas that I have, but it's really infusing the strategic advocacy choices that they've already made with data that we have collected to support that.
Great, thank you. I had a question for Dr. Moran. Actually a couple. I'm thinking about your kind of program and what you're testing, and then I'm thinking, because UCSD is my health system as well, so I fill out lots of questionnaires and stuff in my chart. I'm wondering how your work could fit with other initiatives, and if there's been sort of discussion of integration with, for example, Sarah Linke's work and the exercises medicine piece, and how does it fit broadly?
Yeah, yeah, it's a really good question in terms of making this sustainable. Obviously, Dr. Linke and I are, colleagues, and I've been a big proponent of launching exercises medicine throughout our healthcare system as well. I will say that the question fatigue is an ongoing issue, and the way that we've designed this pilot is really to start targeting the people that are more at risk, more likely to benefit from these questions, more so than a shotgun approach. It's certainly not as comprehensive as it could be, and perhaps hopefully we learn from it to say maybe we could include other people we haven't thought of. But the program is really launched to target people coming in for their Medicare wellness exam, which inherently mean that they're on Medicare, which with some exception mean they're 65 and older. So the questions are also not asked systematically. That was part of the first iterative version of our workflow that we designed. It was one that Dr. Siddipati, who's our CMIO and our division chair, was a big proponent of, to say this should be routine clinical process. This is something that should be happening. This is standard of care. This is evidence-based care, and we should be offering it to every patient every single time. And for the very reasons that were highlighted there, the question fatigue, that's one of the main issues, that the processes really do take at least 7 minutes of nursing time, which is a huge clinic flow buster. So instead, we designed the people who are otherwise interested, either through banners that we put into in clinical rooms, as well as in the soon to be in the waiting rooms, as well as either from identification of the PCP or through some other measure that we try to incorporate in the EMR to be as least burdensome to the clinical stakeholders as well as to patients as possible. I hope I answered that question.
Yeah, I think so. And there's just a follow-up from Dr. Stadnick thinking about sustainment. Are the group-based visits that you described, are they eligible for reimbursement?
This has been a great question. This is something that I've spoken with a lot of the people from the Exercise and Physical Activity Resource Center, EPARC, who, it's experts in exercise science, about whether or not, we could get someone like a physical therapist to provide that sort of clinical expertise alongside the exercise science students who are often running this, as well as exercise scientists. And, that's something that we're looking at. I'm so low on the totem pole, I don't want to misspeak here, but I will say, dealing with billing is a very complicated thing. It depends on whether or not someone has a supplement. It depends on whether or not they have a high deductible plan. If they just have Medicare Part B, you're talking about how many physical therapy have they already utilized for the year, and whether or not that would be double dipping there. So that certainly is something we're exploring to make this more widely, widely and readily available. Currently, there's a kind of a carve away, which probably will go away soon, saying that televisits don't have a copay. That's been a huge benefit for us, actually. That's one of the main reasons we designed this to be by Zoom. So, it's kind of a moving target. I'm kind of going off tangent here, but that is one of the ideas we really had hoped to do, but currently not the case.
Yeah, thank you. So I'm going to selfishly, one of my questions for Dr. Treichler. So VA is a big behemoth with lots of levels, and you're doing this wonderful engaged and collaborative work. I'm wondering how it's viewed when we think, at the, you're on a psychiatry service, hospital level, at the VISN level, and how these things are sort of viewed and supported in the larger VA system. So just thinking about that system level piece.
Yeah, that's a great question. I think you're right. The VA is a very complicated, some people call it like a ship, and it's really hard to turn the ship. One of the great things I think about the VA is that they are very invested in veterans. They're very invested in veteran satisfaction and veteran engagement. And so the idea of kind of veteran-centered care is very much in the interest of kind of the higher ups, the administration of the VA, and that can help with ideas like this that can seem very progressive and not in line with kind of typical medical care. That the administration is really focused on making sure that veterans are happy and that veterans feel heard. And so sometimes that can get you around things that otherwise they might be wary of. And that there are also a lot of veteran advocacy groups within the VA. And so when you have kind of the ear of some of those groups, you often get a little bit more headway. And I think we see that with some of the existing initiatives in the VA, like Whole Health, which is a much more holistic model, and Peer Services, which is veteran to veteran provided services, for example.
Great, thank you. And then another question from Claire. Could you discuss a little more about the rating process for adaptations and how you'll analyze those data?
Yeah, so we have taken a somewhat similar approach in the adaptation for the VA more generally of the same intervention, where we did an iterative process with veterans and VA clinicians, and we identified our kind of potential adaptations through an iterative process, but at 2 stages. We asked those stakeholders to just rate those potential adaptations in terms of how impactful they thought they would be, how much veterans would find them easy to engage in, how much clinicians, or how easy it would be for clinicians to deliver. I think there might have been 1 or 2 other items that we asked them to rate them on. And that was based, Claire, I saw that you asked about like existing methods papers, and I think we did base it on a paper, and I can look for it. It's not coming to mind who the author was on that. And it was just kind of a way for us to find out, like, we talk about a lot of ideas, but how many of these are really important to the stakeholders that are bringing them up versus them just being kind of something that we discussed during a conversation, but it may not really end up being something they think is important enough for us to follow through with, especially when sometimes we do find that stakeholders bring up things that are at odds with each other, and we can't do all of them. So which one of these is the most important? And so we'll do something very similar in this. We'll just ask people to rate those potential adaptations in a couple of domains like that, so we can get a sense of what's going to be the most impactful. And if we do need to pick between different ones, which one should we pick? Especially because in this case, we can't be iterative.
Yeah, and it's great. It's part of that collaboration process, and managing that is no small task, but looks like you're doing wonderful work. So that really brings us, unfortunately, to the end of our time, because each of these projects would love to hear more and ask more. But thank you all, and we'll be looking forward to hearing further progress on your projects as well.